on nephrology. Today is our last topic from nephrology, approach to nephritic and nephrotic syndromes. We have Dr. Jayaprakash, who's the assistant professor in the Department of Nephrology. He will take us through the topic. Over to you. Thank you.
Am I audible now? So, good afternoon, friends. The topic for today's presentation is approach to nephritic and nephrotic syndrome. So, this is one of the common clinical case we are encountering in our like day-to-day practice. But many times it is not diagnosed properly, or sometimes it's managed improperly. So, I am going through the following topics. First, we will go through this physiology of this glomerular filtration barrier. Then, so how these glomerular diseases present clinically, and what are the clinical syndromes of these glomerular diseases, then pathogenesis, then how will you evaluate these glomerular diseases, then finally the management. I'm not going into the management of these individual glomerular diseases because it is a very big topic. I'm going to elaborate about that general management of this common glomerular and nephritic syndromes. So this is the enlarged view of this glomerulus. Yeah, this is a like single glomerulus which is made up of, which contains this one afferent arteriole which enters into the glomerulus, which divides into multiple glomerular capillaries. Then it exists as efferent arteriole. The entire glomerular capillaries are covered by a membrane called Bowman's capsule. There are 4 important cells which we should know in glomerular pathology. First is this is the enlarged view of a single capillary loop, which is made up of that. This is the capillary lumen, which is lined by capillary endothelial cells, which has multiple fenestrations. That is it's called fenestrated endothelial cells. Then glomerular basement membrane. Then outer side, it is attached by the specialist cell called visceral epithelial cells, also known as podocytes. These podocytes, it's not like a normal cell. It contains multiple food processes. Like its cell body is like divided into multiple food process which attaches to the external surface of the glomerular basement membrane. This is that longitudinal section of the single capillary loop. The outside you can see this podocytes. It entirely covers the outer surface of the glomerular capillaries. It is not like a single podocyte. It contains multiple podocytes which extends its food process, which will interdigitate. They form like this. So this is some more extended, like a zoomed view of the glomerular filtration barrier, which is made up of mainly contains 3 layers. One is internally, it is a fenestrated capillary endothelium, then glomerular basement membrane, then externally it is these the food processes. The space between these food processes are called filtration pores, which the adjacent food processes are held in position by means of this slit diaphragm. Slit diaphragm is made up of multiple proteins like nephrin, podocin, lots of more than 50-60 types of proteins are available. These proteins are also very important in our topic because any mutation in these proteins can lead to like alteration in the glomerular filtration barrier, leads to this proteinuria or some other pathologies. This is the electron microscopic view of the part of a glomerular filtration barrier. You can see this central band-like thing is a glomerular basement membrane. This is the inner side, that is a lumen, capillary lumen. This is a single endothelial cell which extends its body, which has multiple fenestrations. This is the first layer which comes in contact with the blood. Then next to it is the glomerular basement membrane. Actually, in electron microscopy, it is divided into 3 parts actually. Here you can see. The inner thicker part is called lamina densa, that is electron dense part. Then the glomerular basement, which is towards the endothelial cell, is called lamina rara interna. The external outer towards the podocyte is called lamina rara externa. Then this outer part is, these are all the food processes. Here you can see a single podocyte, how it extends its food process to this, like this. So coming to the clinical manifestation, how these glomerular diseases manifest clinically. There are multiple ways. First thing is either they can manifest in the form of hematuria with or without proteinuria. So as per definition, hematuria means presence of blood in the urine. But for us, For microscopic hematuria, you have the cutoff actually. It is like more than or equal to 3 RBCs per high power field in the urine. But actually, it is not absolute criteria. It is based on multiple studies. We are also following the same thing. So, and for hematuria, there are multiple reasons. It can be glomerular or non-glomerular also. Non-glomerular means just below the kidneys, like from the ureter or from the bladder also. So you have to differentiate how this glomerular hematuria will present. So main thing is that they are having this dysmorphic RBCs. Dysmorphic means the structures will be altered, not like rounder shape actually. Because so what is the reason for this dysmorphic RBCs are? Because normally these RBCs are present in the capillary lumen here. But whenever there is any pathology in this glomerular filtration barrier, like any injury to the endothelium or glomerular basement membrane, the RBCs from the lumen, it try to enter into the this urinary space. In between this space are called urinary space. So because of high pressure inside the glomerular capillaries, the RBCs try to come out of this lumen. So when it passes through that defect, the membranes gets damaged, so leads to altered structure. And also when it came out of this capillary lumen, enters into the urinary space, when it passes through the tubular fluids, because tubular fluid like proximal, distal, loop of Henle, multiple parts are there. Each has different osmolarity, tubular fluid. So when the RBCs is exposed to these different osmolarities, hypoosmolar, then hyperosmolar in the medullary interstitium, then again hypoosmolar, like that. So because of this varying osmolarity, this RBC membrane gets further damaged, leads to this dysmorphic shape. So what is the criteria proposed for this to confirm it, to consider it as a glomerular hematuria? One is the number of RBCs. It should be more than 40% at least. Then presence of 5% or more acanthocytes. Acanthocytes are a part of a type of a dysmorphic RBC with some round blob-like appearance. I will show you next. Next, presence of at least one RBC cast is considered as a glomerular hematuria. So either one should be there. But it is not, this is also not a strict criteria. Based on different studies, we are considering this as a glomerular hematuria. So clinically, this hematuria can present as a microscopic or macroscopic. Microscopic means patient may not aware of this hematuria at all. So this can be diagnosed only when there is when the patient comes to hospital for some other reason. Just incidentally, we can find this microscopic hematuria. This image showing this is a RBC cast, and this is a single acanthocyte. This is a phase contrast microscope showing this round RBC with some external blob. This is called acanthocytes. So second manifestation is proteinuria. So proteinuria is also a hallmark of a glomerular disease like hematuria. So but normally you will not see any proteins in the urine except just some minimal proteins, like maximum protein excretion per day is like 150 milligram per day. That too like tubular proteins. Tubular proteins means that contains some TAM hospital protein which are secreted by the tubular epithelial cells, and some alpha 2 microglobulins and alpha 1 antitrypsin. Those proteins only. Albumin will be very minimal because it will not reach that urine, because it whatever it is filtered, it will be reabsorbed by the proximal tubules. So nothing will be there in the urine. So this is the KDIGO categories of this proteinuria. So this is a normal protein excretion is like we can measure both albumin as well as protein. So what is the normal albumin excretion is less than 30 milligram per day. Normal total protein excretion is 150 milligram per day. So when will you consider is moderately increased or severely increased? Actually, this mildly increased also, usually albumin will not be there. Sometimes 15 to 30 milligram also possible. That's why it's called mildly increased actually. But what is moderately increased category means when the albumin excretion is more than 30 to less than 300 milligram per day is called moderately increased. Previously, this was termed as microalbuminuria. Currently, the term microalbuminuria, subnephrotic protein and all not in use actually. So this is a new name given for this proteinuria. So if the albumin excretion is more than 300, it is called severely increased albuminuria. If the total protein excretion is more than 500, it is severely increased proteinuria. And one more thing is this single measurement of only albumin or protein is not useful clinically, because it is most of them it will be error, because many patients the protein excretion will be altered by patient's hydration status, patient's body weight, like that. So always we should measure along with creatinine. So we have to calculate this ratio that will help us whether the that can be used to compare the protein leakage in different population also. So what is the normal cutoff for albumin creatine ratio is like what we are using is less than 30 milligram per gram. This is almost same like this thing per day like that. And moderately increased albumin ratio is less than 30 to 300. If it is more than 300, it is severely increased. Regarding this protein creatine ratio, the cutoff also same like less than 150 milligram per gram or 150 500 more than 500. Then protein reagents dipsticks test also can be used to measure the proteinuria, but it is a semi-quantitative method. It's not accurate method. Can be used as a screening method, not as a cannot be used for quantification. So other clinical manifestation is renal insufficiency. Many patients may come to hospital with like severe azotemia, like uremic symptoms, oliguria, or fluid overload symptoms. So how these like among our glomerular diseases, nephrotic and nephritic syndrome, this renal dysfunction is very rare in nephrotic syndrome because they have mainly proteinuria, but renal dysfunction is very rare, but only some exceptional conditions. Like if the patient, because of severe hypovolemia, they may have depleted intravascular volume, leads to like pre-renal component, might have induced this AKE. Other thing is when patient may develop some renal vein thrombosis because of severe hypovolemia, which is a procoagulant state. That can also lead to renal dysfunction in nephrotic syndrome. And other reason can be due to use of some medicines. So like outside and all, they may give some diuretics or some painkillers. Those things will affect tubular integrity. So AKE is very rare in nephrotic syndrome, but it is very common, just opposite in nephritic syndrome. So nephritic syndrome usually present with renal dysfunction. That too in very severe cases, like in crescentic GN, they will have this renal dysfunction. It may require dialysis and immediate treatment. Some rarely these patients may not be aware of these clinical condition at all from the early stages. So they reach the hospital only at the end stage. So at this stage, we cannot do anything because they may have this problem for a long time. Slowly, the tubules might have get damaged, leads to severe interstitial fibrosis, tubular atrophy, leads to this CKD stage. So another important presentation is hypertension. It can be either in the presence of like it can present as acute onset hypertension, like in most commonly in IgA nephropathy or IRGN. They can present with hypertension related flash pulmonary edema like that. Second presentation is like unexplained hypertension in young age. So any young patient presenting with hypertension, you have to rule out the renal causes. Along with these endocrine causes, the renal causes include one is glomerular disease, second one is renal artery stenosis. So you have to rule out if urine is showing some hematuria or proteinuria, you have to consider this also as one of the DD for the same hypertension. Third presentation is can be acute worsening of the pre-existing patient may be already having hypertension, but suddenly this time, even though with the regular medicines, suddenly BP, they may present with accelerated hypertension or some emergency like that with flash pulmonary edema like that. So last presentation is a asymptomatic urinary amnesia. In this patient may have this proteinuria or hematuria. They may not be aware of that. They will not have any symptoms at all. It can be diagnosed only during the routine screening. So based on this, so what are the clinical syndromes of these glomerular diseases? It is all based on how clinically they present with and the extent of the urinary abnormalities and the extent of renal dysfunction. So it can be either asymptomatic hematuria or proteinuria, or sometimes combination of both, or sometimes they may present with isolated macroscopic hematuria, like in IgA nephropathy. They will have some episodic macroscopic hematuria, but they will not have any other issues. Sometimes this can be picked up only when, like in the hospital, only when the patient is having acute hematuria at that time. So other in between hematuria, patient will be that urine test, everything will be completely normal. They will not have any evidence of glomerular disease also. So, and another thing is that this glomerular hematuria generally will not produce any clots like non-glomerular hematuria. They usually present the bladder clots and all, but here you will not see any bladder clots and all because this glomerular hematuria is associated with the excretion of like antithrombotic, anticoagulant factors in the urine also. So that leads to, and another thing is this because this glomerular bleeding is very minimal and it will be diluted with so much amount of urine. So it will not produce any clots actually. So another presentation is nephrotic syndrome and nephritic syndrome and rapidly progressive GN. It is one of the severe form of a nephritic syndrome. Then last stage is the chronic glomerulonephritis. So our topic is on this nephritic and nephrotic syndrome. So nephritic syndrome, as the name indicates, it is due to the inflammation of the, both are actually inflammation of the glomeruli, but nephritic syndrome associated with very high severe inflammation. So how to diagnose this? What is the clinical criteria? How to pick up this nephrotic syndrome? The mandatory criteria is nephrotic range proteinuria. That means more than 3.5 gram of protein at least in the urine per day, or protein creatine ratio, spot ratio more than 3 in an adult, plus hypoalbuminemia, presence of low albumin in the blood, like less than 3.5 gram per deciliter. If the patient is not having this albumin report, edema. Edema also one of the major criteria for the diagnosis of nephrotic syndrome. So other criteria, previously this hyperlipidemia also was included as a major criteria, but now that is removed actually. It is considered as one of the ancillary criteria, like dyslipidemia or lipiduria can be present. Lipiduria means excretion of these fat globules in the form of fat droplets or whole fat bodies, sometimes fatty cast. These fat droplets can combine with like some excreted proteins in the urine, can form this Maltese cross appearance in the polaris like this. This is a polaris microscope showing this symmetrically this Maltese cross appearance. This is a fatty cast in the urine. So what are all the conditions that can present with nephrotic syndrome? It can be primary or secondary. Primary means the primary problem is in the glomerular filtration barrier, that is mainly in the podocytes, related to podocytes only. So like what are all the primary nephrotic syndromes? These are minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, and membranoproliferative glomerulonephritis like C3G and dense deposit disease. Actually, here the problem is in the complements, not in the circulation. Actually, this complement relating factors in the podocytes. Okay, that's why it is considered as a primary. But this can happen in systemic deficiency also. So, what are all the secondary causes of this nephrotic syndrome? There are a number of factors are there. Any type of infection, autoimmune diseases, malignancy. So each category you have to divide it into these etiologies: infections, drugs, malignancies, genetic disorders like that. So podocytopathy commonly, the most common secondary cause is like use of NSAIDs. So we are using these NSAIDs around the clock. So that can produce this podocyte. That this patient can present with nephrotic syndrome with interstitial nephritis. Okay. And membranous nephropathy is commonly seen in this lupus nephritis and secondary to some infections like hepatitis B. Whereas MPGN pattern can be seen in many of the autoimmune diseases like SLE, and even other autoimmune diseases like cryoglobulinemia also can produce, and infections. Any type of infection can present with the immune complex mediated GN, like membranoproliferative pattern. And then glomerular deposition disease. It is due to deposition of the some circulating abnormal proteins, like in case of this amyloidosis, and some monoclonal deposition like MIDD, immunoglobulin deposition disease, immunotactoid disease, fibrillary GN, all this. And some hereditary disorders like due to some genetic defects, Alport syndrome, nail patella, Fabry's. And other conditions, the most common secondary cause is diabetes mellitus. So what is nephritic syndrome? Nephritic syndrome is inflammation of the glomerulus mainly. So how it this presents? It can present with glomerular hematuria with variable degrees of proteinuria. That means they may not have any protein in the urine, or sometimes they can present the nephrotic syndrome also. So this can be considered as nephrotic nephritic. Sometimes they will have this leukocyturia because of glomerular inflammation along with RBCs. WBCs also can be excreted through the urine. And hypertension. Hypertension is also common in nephritic syndrome than the nephrotic, because nephritic syndrome, it is associated with glomerular inflammation which can activate the ROS system. So that's why this glomerular disease, this nephritic syndrome commonly associated with hypertension. And the main reason for fluid overload in this patient is like there are three theories are proposed for the edema in renal failure. One is underfill and overfill theory. Here it is mainly this overfill theory. Due to excess activation of the ROS system, excess sodium retention leads to this fluid overload. Then renal failure. Renal failure is also common in nephritic syndrome. But this nephritic syndrome can present like within few days to few weeks to, it can present as a chronic CKD. So within few days means it's acute. RPGN means rapidly progressive glomerulonephritis. That means within few days to weeks actually. So chronic means it's like a chronic more than 3 months. Actually. So what are the glomerular diseases associated with nephritic syndrome? Can be primary or secondary. So here you can see some of the diseases can be seen in nephrotic also, nephritic also, because there is no strict thing. These all are due to glomerular inflammation. So it can manifest initially as nephrotic syndrome, then later turn into nephritic also possible. So like this membranous nephropathy and immune complex mediated this MPGN, C3GN, IgA nephropathy. IgA nephropathy is primarily a nephritic syndrome, but very rarely less than 5% can present with nephrotic also. And anti-GBM disease, anti-glomerular basement membrane disease, and idiopathic crescentic GN. So these can present like RPGN also, rapidly progressive renal failure. So what are the secondary causes of this glomerulonephritis? Post-streptococcal or any, currently this term is not in use. So any type of infection can cause this GN. So that's why it's currently it is called infection related GN, IRGN. Then infective endocarditis, IgA vasculitis, SLE, and granulomatosis polyangiitis. Here is SLE also initially can present with asymptomatic hematuria proteinuria, then nephrotic range proteinuria, then nephritic syndrome, can present in any ways, can present with RPGN also. So what is RPGN? RPGN means it contains all the features of nephritic syndrome along with rapid worsening in the renal dysfunction over days to weeks. So this is a very severe form of a nephritic syndrome. So it is characterized by renal biopsy will have this extensive glomerular inflammation leads to this crescent formation. Sometimes necrosis also, glomerular necrosis also. This biopsy we will discuss later. So if you don't intervene this patient immediately, ultimately this patient reach ESRD in few weeks. So how will you classify this RPGN? It is all based on this immunofluorescence finding. So there are three types, actually total 5 types are there. These 3 most common types. Type 1 is anti-GBM disease. It is based on its IF finding, linear IgG deposition in the glomerular basement membrane. It's an anti-GBM disease. Type 2 is immune complex mediated. It means deposition of some immune complex in the either subepithelial, subendothelial side. Immune complex means immunoglobulin plus complements. Both should be there. Then type 3, the example for this type 2 RPGN is like SLE, IgA nephropathy or IRGN, like that. So type 3 is a passive immune. Passive immune means they will not have any evidence of immune deposition in the immunofluorescence. So IF will be completely negative. So examples are this ANCA vasculitis, like any type of ANCA vasculitis, like GPA, EGPA, granulomatous polyangiitis or eosinophilic microscopic polyangiitis and eosinophilic granulomatous polyangiitis. So this is the difference between this nephrotic and nephritic syndrome. So usually this nephrotic is a gradual onset, nephritic is acute presentation. The edema will be more in nephrotic than in nephritic. Blood pressure will be normal in nephrotic, sometimes low because of depleted intravascular volume. So it will be high, BP will be high in nephritic syndrome. And JVP also, like BP and JVP will be elevated in nephritic syndrome. And proteinuria will be more in nephrotic, comparatively less in nephritic syndrome. Hematuria will be there in nephritic, it will not be there in nephrotic. And RBC cause present in nephritic. And serum albumin will be normal in nephritic, but it should be low in nephrotic syndrome. So why some diseases are presenting with nephrotic, why some are presenting as a nephritic syndrome? It is due to the difference in the pathogenesis actually. Some diseases are immune mediated, some are non-immune mediated. So majority of the glomerular diseases are mediated by some abnormality in some abnormal activation of the adaptive immunity, like both cellular and humoral factors will be involved in this. So to activate this adaptive immunity, there should be some antigenic targets. So what are all these antigenic targets? These targets can be a normal constituent of a glomerulus, constituents of a glomerulus, or sometimes some non-renal self antigens can be deposited in the planted in the glomerulus, leads to inflammation. Sometimes exogenous out of the body, some infection or something entering into the body, producing inflammation. So it can produce 2 types of lesions, inflammatory and non-inflammatory lesions. These are all some examples of like different pathogenesis. One is the infection related agent. It is due to some exogenous antigens. One thing, it can produce, like after entering into the body, it will elicit some immune response, produce some antibody response, forming antigen antibody complex in the circulation. It can get deposited in the glomerulus when it passes through the kidneys, leads to local damage and inflammation. That is one thing. Second thing is molecular mimicry, also possible in IRGN. So some, like in post-streptococcal glomerulonephritis, some antibacterial proteins can mimic with the glomerular proteins. So when these antibodies are produced against that antibacterial antigens, can affect the self-renal antigens also to produce this inflammation in the kidneys. Second is autoimmune gene. Autoimmune gene means it is autoimmune, so self antigen but non-renal antigens. So this, like in SLE, this auto antibodies are formed in the circulation, forming immune complexes getting trapped in the glomerular filtration barrier, leads to inflammation. This alloimmune transplant, this auto-inflammatory conditions, mainly this secondary amyloidosis, like auto-inflammatory means like familial Mediterranean fever is one of the auto-inflammatory. It is due to excessive production of the inflammatory markers like inflammatory proteins like SAA, serum amyloid associated protein. Due to abnormal folding and all, it can get deposited in the kidneys, producing inflammation and damage. And finally, this abnormal deposition of abnormal proteins itself, like monoclonal gammopathy related, like it can be deposition of, it can deposit as amyloid fibrils like AL amyloidosis, or it can present with the MIDD, monoclonal immunoglobulin deposition disease, or sometimes proximal tubulopathy also. So depends on the location of immune complexes, the clinical presentation also varies. Like if the immune complex is deposited in the subepithelial side, subepithelial means towards the podocyte side. So towards the podocyte side means in between glomerular base membrane is also there. So the contact with blood is minimal. So the inflammatory cells will not reach this level. So this will damage only the podocytes. So these subepithelial deposits usually will have less inflammation because it is also inside the urinary space. So even if some inflammatory cells are entering into this space, it will be flushed out through the filtrate actually. So that very less time for the inflammation to become more severe. So these subepithelial deposits will not produce severe inflammation. So that's why it will injure only podocytes, sometimes this basement membrane also. So mainly these subepithelial deposits present with proteinuria. So like nephrotic syndrome. Hematuria will be less in this. Like in membranous nephropathy, the deposits will be in the subepithelial side towards podocytes. And in minimal change disease also, the injury is to the podocytes only, not in the GBM or endothelium. So that's why they will not have hematuria. And then subendothelial deposition. Subendothelial means many of the inflammatory conditions, or most of the immune complexes like SLE and all, it is subendothelium means just below the endothelium. So it is in close contact with the blood. So more inflammatory cells will attack this this local part. So it can damage the endothelium as well as glomerular base membrane. So if GBM is breached, leads to blood loss like hematuria. So that's why this subendothelial deposit will produce more inflammation and more proliferation. Proliferation means more number of inflammatory cells are entered into the area. Then so because of more endothelial damage and GBM damage, they will have hematuria. Whereas basement membrane deposits like dense deposit disease, they can present in either way. They can have proteinuria and hematuria. So in inflammatory conditions, they will elicit predominant endothelial injury, leads to proliferative lesions. So they can present as nephritic or RPGN presentation. Okay, so examples are infection related GN, ANCA vasculitis, SLE, and IgA vasculitis. Whereas non-inflammatory lesions that will affect only the podocytes, either podocyte damage or dysfunction. So these will not have any inflammation, so they will not have any much proliferation also. So they present with nephrotic syndrome. So examples are this MCD or membranous glomerulonephritis. So what are all the reasons for this non-immune mediated this glomerular injury? One is because of presence of these permeability factors like anti-nephrin antibodies in MCD, or FSGS is due to because of some SUPAR. It is called some factor like some circulating factor that causes podocyte dysfunction. It will not elicit inflammation, but it causes podocyte dysfunction. It will alter the podocyte cytoskeleton, leads to the dysfunction. Some toxins, toxin-induced podocyte damage, or some genetic mutations affecting only the podocyte food processes, or some hyperfiltration related. It is mainly on secondary FSGS. So all these conditions, only podocytes are affected, so leads to predominantly proteinuria, nephrotic syndrome. So how will you evaluate these glomerular diseases? First thing is history is very important, followed by clinical examination. Then urine routine, urine analysis in the form of urine microscopy plus urine dipstick, then protein quantification. Then along with you have to check for the renal dysfunction, quantify like severity of the renal failure, then severity of hyperuremia. Then once if you confirm that nephrotic or nephritic syndrome, then you have to search for the secondary causes. You have to do lots of serology things based on depends on your diagnosis. Then finally genetic testing and serology followed by renal biopsy and genetic testing. Renal biopsy is also very important before that. So what are all the clinical history? How will you approach a patient? First, when we are seeing the patient first time, so you have to ask what is the duration of symptoms, how it started, and now, like whether it is static or it is progressing now, or whether he had a same type of illness, similar type of illness in the past that in between it was in remission, now again relapsed, or whether it is only proteinuria. Proteinuria means they will have the frothiness and all, or whether it is associated with some hematuria, blood in the urine, or blood means some patient may say some dark color urine. For example, in IRGN, they will say it's like cola color urine, or patient may have any history of renal failure. And regarding hypertension history, whether the patient had new onset hypertension or previously he was having hypertension, now this currently it is not controlled well with the same medicines, or presence of any extra renal symptoms that we will see next, and any history of recent infection, any type of infection, not only throat infection or skin infection, any type of infection like any intra-abdominal or anything can cause this respiratory or urinary infections. History of any recent drug intake, what type of any NSAIDs or any other like specific anti-inflammatory drugs that can produce nephrotic or nephritic syndromes, or treatment history, whether he had the same type of problem in the past, how it was treated in the past, then any comorbidities, whether it's a diabetic hypertension or whether it's any other like pulmonary symptoms. Mainly diabetes is very important because diabetes can present with nephrotic syndrome, and family history. Any family members having the same type of illness like nephrotic syndrome present or nephritic syndrome or rapid RPGN present in the family, or history regarding complications. This nephrotic syndrome may present with one when they develop complications like in the form of like severe respiratory failure in the form of because of this pleural effusion, severe edema, ascites, sometimes peritonitis, sometimes they will present with the AKA due to this renal vein thrombosis, some infections like that, peritonitis, sometimes cellulitis. So what are the extra renal symptoms? Because many type of diseases can present with nephrotic and nephritic syndrome. So mainly connective tissue disorders. You have to ask some history related to connective tissue disorders, mainly SLE, vasculitis, whether he had any hemoptysis, or related to lungs, abdomen, whether he had any enteritis, colitis, pancreatitis, any history of seizures, any history of mainly skin examination is very important. Skin history, whether he had any skin lesions, and arthritis. Many patients may have this arthritis or arthralgia. Then any history of infection. So examination wise, both the patients, both nephrotic and nephritic can have this edema. But nephrotic edema, like initially it start with usually or most of the renal conditions, nephrotic, this edema will start in the dependent part, mainly in this periorbital puffiness, it may start, or sometimes they will have this pedal edema. So usually the patient will not have any like features of edema unless until it like the fluid accumulation crosses more than 4 liters. If the flow like 70 kg normal adult, he may not have any features of edema unless the fluid accumulation crosses more than 4 liters. And regarding JVP, jugular venous pressure will be low in nephrotic syndrome, or low or normal. Nephritic syndrome, it will be high. Whereas except one in amyloidosis, JVP will be elevated because of cardiac amyloidosis. And any evidence of drug toxicity, whether the patient had similar symptoms in the past, he received some medications like steroids or some tacrolimus or some endoxone, whatever medicines he received, whether he had some toxicity related to the drugs. Any like steroids means like they will have the Cushing-Hart features and this buffalo hump, all those things, stray and all. And regarding blood pressure at presentation, whether the patient is having normal BP or whether the patient is having hypertension or not. And regarding retinal status, if the patient is having diabetes, you have to check for the retina, whether the patient is having diabetic retinopathy, because diabetic nephropathy correlate with the diabetic retinopathy. That is important. Some vasculitis and all, they may have retinal vasculitis also. And regarding amyloidosis, those you have to check the retina. And hypertension also, that you have to check for the hypertensive retinopathy changes. Then any other features of connective tissue disorders, whether the patient is having joint swelling, rashes, or any features of like SLE, like alopecia, like rashes and all, molar rash and all. Then any other syndromic features. If you are suspecting some genetic diseases like Alport syndrome, whether the patient is having any eye issues, any lenticonus, or sometimes hearing issues. So coming to the lab evaluation, lab investigations, first step is you have to do the urine analysis to look for hematuria and proteinuria. Then proteinuria means first qualitative, then followed by quantitative. Then regarding renal failure status, what is the whether the patient is having uremia, azotemia, dyselectrolytemia, then serum protein levels, whether the patient is hypoalemia or not, then investigations to rule out the secondary causes, then renal, finally this renal biopsy, then genetic analysis. So coming to the proteinuria, hematuria we already discussed. Proteinuria, there are three methods are used. One is that dipstick method. It's a semi-quantitative method followed by 24 urine protein, then spot urine protein creatinine ratio. In this semi-quantitative method, this urine dipstick, this is the first screening test. So it can detect only albumin. So it can, why it is called semi-quantitative means you cannot quantify the protein. It will show only 1 plus 2 plus 3 plus 4 plus like that. So usually if dipstick test is positive means it is albuminuria is there, then some glomerular pathology is there. That will confirm. So, and before analyzing a urine dipstick test, you have to see whether the urine is like having this appropriate specific gravity. Sometimes if the urine is over diluted, you may not pick up the proteinuria. Or if the urine is very much concentrated, even without proteinuria also, patient may show 1 plus 2 plus positive like that. So before that, you have to check the specific gravity first, whether it is within the normal range. Then you have to analyze the this protein status. So usually negative means it is less than 15 milligram per day per deciliter, and 15 to 30 is trace positive. So up to trace, you don't need to worry. So above, if it is 1 plus means it is more than 30 milligram per deciliter. So it is like 30 to 100, 1 plus, 100 to 300, 2 plus, 300 to 1000, 3 plus, then more than 1000 is 4 plus. But may not be always correct. It depends on the dilation status, the concentration of the urine. So next is the 24-hour urine protein creatinine ratio. So this is the gold standard method because many times this is the most accurate. Because if you are seeing any patient, if you are suspecting some glomerular disease, always do the 24-hour urine protein creatinine ratio, not 24 urine protein alone. You have to do the creatinine ratio also, because this protein excretion, because many times patient may not collect the urine properly. If they under collected the urine, if you estimate the protein, quantify the protein, it will be less. It may miss that nephrotic proteinuria. If the patient, sometimes if you advise the patient to collect 24 urine, patient may think that, oh, doctor is advised to me to collect the urine, so they will drink lots of water, then they collect. Sometimes they pause, they drink more than 3 liters, 5 liters, 6 liters also, they collect 5 liters, 6 liters also. If you see the urine protein, it will be like more than 4 grams, 5 grams. But actually, if you compare with the creatinine ratio, sometimes it may not be nephrotic also. Okay. So, and urine protein excretion also vary with the patient's weight also. So that's why we are using this urine creatinine ratio. So to before checking that protein levels, you have to check the creatinine, whether you have to check the adequacy of collection. So how to check the adequacy means normal this creatinine excretion in adults, in males like around age 50 to 70, it is like males it is 18 to like 22 milligram per kg. 18 to 22 milligram per kg creatinine excretion is normal per day. For females, it is like 11 to 16. If it is a younger age means the cutoff will be even more actually. So first you have to assess the adequacy. If you are calculating the 24 total creatinine levels, like for example, it's a 50 kg male, 50 years old. So if you are using the 20 milligram per kg means 15 to 20, probably 1000. So in your urine sample, if it is around that level, 900 to 1100, it is collected adequately. If it is like 2000 and all means you might have collected too much. Or if it is less than only some 500 mg only there means it is under collected sample. So you have to repeat the sample. The problem with this 24-hour protein creatinine is it's very difficult to collect. Many patients may miss actually. You have to advise the patient to start collecting from the second morning sample to the next day's first morning sample. And next is that random spot PCR, urine protein creatinine ratio. This is simple to do, but you have to advise the patient to collect the second morning sample. The problem is lots of inter-individual and intra-individual variation will be there, because patients are sometimes it's a hydration status, patient's body weight will alter the ratios. So coming to the categorization of this proteinuria, the severely increased proteinuria, it is considered nephrotic syndrome when it is associated with hypoalbuminemia. If proteinuria is more than 3.5 grams, but there is no hypoalbuminemia, then it is called nephrotic range proteinuria, but not nephrotic syndrome. So non-nephrotic proteinuria means between the levels, between normal 300 milligram to below 3.5 grams is called non-nephrotic. So before considering this proteinuria as pathological, you have to rule out some non-pathological conditions like transient proteinuria can be seen in fever, heavy exercise, some like exertion and all. So the many times these proteinuria will never cross more than 1 gram. Usually it will be below 500 only, 500 milligram only. These are just albumin protein, albumin leakage. Then second type is the orthostatic proteinuria. Orthostatic proteinuria means proteinuria will be there when the patient is in standing position. When recommend position, it will not be there. So this is orthostatic proteinuria, but it is very common in younger patients. But it is mostly it is a benign condition. So to confirm this orthostatic proteinuria, you have to use the split urine collection. That means daytime standing position, you have to collect the urine. Then you have to collect separately in the nighttime urine. So many times this also less than 1 gram only. So no need to do anything for this. This will many times it will resolve automatically. And then persistent proteinuria. Regarding persistent proteinuria is overflow proteinuria. Overflow proteinuria means mainly it is due to excretion of non-albumin proteins like myeloma, hemolysis, hemoglobinuria, myoglobinuria. This also mainly mostly it is a subnephrotic. Sometimes in case of myeloma it can be more than 20 grams also, but it is of non-albumin. So how to diagnose this problem? Like simple method is if you do urine dipstick test, it will be negative. But if you do 24-hour quantification, it will be more than 20 grams, 30 grams also possible. So obviously diagnosis, you can diagnose this as a overflow proteinuria, myeloma something. So next is glomerular proteinuria. As we already discussed, it can be like non-nephrotic to nephrotic. Mainly it's predominantly albumin. Other is tubulointerstitial proteinuria. Tubulointerstitial proteinuria is due to some damage in the tubules like in cystinosis or some tubular injury can produce protein leakage. Usually it will be less than 2 grams only. It's not 3 grams, it's less than 2 grams only. Mainly non-albumin proteins. And post-renal proteinuria, usually some issue in the urinary tract infection, some bladder tumors. They can secrete some proteins that can be picked up in the urine. So regarding this, next step is serology to rule out the secondary causes. Like these are all the different diseases. Like for membranous nephropathy, you have to check the PLA2R antibodies, PLA2R antibodies. In case of this amyloid disease, plasma-free light chains, electrophoresis. And in case of this nephritic syndrome, post-streptococcal glomerulonephritis, you have to check for ASO titers, ADNB, complement levels. Then in case of IgA nephropathy, no need to measure this. We are not measuring this IgA levels because many times can be abnormally elevated. And lupus nephritis, you have to all lupus serologies, NADC, complements. And regarding this RPGN picture, you have to, for good process syndrome, you have to measure the anti-GBM antibodies. Regarding vasculitis, you have to measure the ANCA titers. So next step is renal biopsy. So many times for children, it is not required. For adults, it is always important to do the renal biopsy to confirm the pathology, because even in adults present with the nephrotic syndrome, this children, it is most commonly it is a minimal change disease, whereas in adults, other pathologies are more common. So that's why it's always renal biopsy is gold standard, and you have to quantify the severity of damage actually. So renal biopsy is indicated in all patients with more than 500 milligram per day proteinuria after ruling out these transient conditions. Then if the patient is having nephritic syndrome, nephrotic syndrome, or RPGN presentation, you have to do the renal biopsy. But except in one condition, it's isolated hematuria. Many times it may be due to this mild IgA nephropathy or thin basement membrane disease or Alport syndrome. Because these conditions, even the renal biopsy will not change the management. So no need of renal biopsy in these conditions. So this, as per the KDIGO, as most of the adult patients, renal biopsy is indicated, except in children less than 12 years and in post-streptococcal glomerulonephritis suspected, no need to do renal biopsy. And in some extreme conditions, if the patient is presenting with severe renal dysfunction, sometimes patient may not be cooperative, or some patient may not be eligible to do the renal biopsy, may be so sick. In those conditions, if your serological evidence of some glomerular disease is there, you can directly treat the condition. Like in membranous nephropathy, if PLA2R antibody is positive, or in case of RPGN picture, if the ANCA titers are very severe and patient is having other clinical symptoms like hemoptysis or diffuse cellular hemorrhage with renal failure, the diagnosis is almost confirmed. So you can directly start treatment. Don't wait for the biopsy report or not. And anti-GBM disease also. So regarding this renal biopsy, three important things: light microscopy, immunofluorescence. That these two is needed for all the patients. Electron microscopy is needed in some selective patients. So first is the light microscopy. There are different stains are used for the in light microscopy. The three commonly used stains, four commonly used stains are this H&E staining to look for the cellularity, and this periodic acid stain to look for the cellularity as well as matrix, as well as glomerular basement membranes and all membranes. Regarding this methylamine silver stain, it stains the GBM and the other matrix as black. And trichome staining, it is used to pick up the scars and degree of that immune deposits, whether it's a blue color or red color. And Congo is used if amyloid is suspected. So based on this light microscopy, we can classify the pattern of glomerular injury, whether it is a focal or diffuse. Focal means like only like if you are seeing some 10 glomerulus, less than 50% of like only 3 or 4 glomeruli are involved, then it is called focal. Diffuse means more than 50% of glomeruli involved, it is called diffuse pathology. And then segmental. If you take a one glomerulus, only a part of glomerulus, less than 50% of size of the glomerulus involved, it is called focal. If it is more than 50%, that is almost full glomes are involved, it is called global. Regarding cellularity, mesangial hypercellular, usually mesangium contains only mesangial cells. Very rarely inflammatory cells are seen. If the mesangial cells like more than 2 numbers are seen, 3 or more, or some inflammatory cells are seen, it is considered as a mesangial hypercellularity. Or crescents. Crescents is a normal, not a normal pathology, a normal finding. It is, if crescents are present, that means excess of inflammation is there, so it's a very abnormal. So cellular crescent is very dangerous, it's very active. Fibrocellular is in between, and fibrosis is a chronic condition. And endocapillary hypercellularity. In biopsies, this I will show you next. In biopsies, these capillary lumens will not have much cells except some RBCs. But if you have lots of inflammatory cells in the capillary lumen, that indicates endocapillary hypercellularity. That indicates inflammation is so severe. And fibrinoid necrosis can be seen in this vasculitis and all. Sclerosis seen in chronic conditions. And based on the findings, it can be minimal, different patterns. Minimal mesangial or mesangial, it's all mainly seen in the SLE. Minimal mesangial and mesangial proliferation is mainly in the SLE. Then active proliferatory gene means excess of this presence of crescents or presence of hypercellularities indicates proliferatory gene. Presence of fibrinoid necrosis, necrotizing gene, and crescentic gene, presence of crescents, more than 50% crescents, if you can call it as a crescentic gene. And then exudative means presence of neutrophilic infiltration, mainly seen in the infection-related glomerulonephritis. Then sclerosis. Next step is the immunofluorescence. Immunofluorescence and to immunoperoxidase. We are using immunofluorescence, but in foreign world, this immunoperoxidase is more common. So immunofluorescence means is used to find out the type of immune deposits, whether immunoglobulin is there or only immunoglobulin or presence of any complements is there or combinations, whether the immune complex is there or not. So these are the following stains are used. There's IgA, IgG and IgM. Then regarding complements, C3, C4 and C1q and fibrin. Then if usually these immune deposits are seen in glomerular diseases, subepithelial or subendothelial. Sometimes in SLE or some systemic diseases, it can be seen in the tubular basement membrane also. Regarding, it depends on the pattern of immune deposits, whether the immune deposits are linear or it is a discontinuous granular. Linear means it is in the anti-GBM disease. So these are all some picture of this immunofluorescence patterns. Here you can see this is in between this mesangial area showing the deposition. Bright spots, it indicates mesangial deposition. Here compared to this, here the in between mesangial part are clear, but only this capillary wall showing some deposits, but that is not regular. Some irregular, some mild deposits are seen. Here both mesangium also there, capillary wall also there. Here mesangium is not there, but capillary wall it is showing like line, single line. It's called linear deposition, mainly seen in the anti-GBM disease. So, some special stains also used to detect if you are suspecting some particular etiology. If you are suspecting membranous nephropathy, you have to do this anti-PLA2 or PLA2 or antibodies. Currently, these lots of newer antigens are antibodies are coming, like anti-nephrin antibodies for MCD. And regarding if you are suspecting fibrillary gene, this DNA JBNN is useful. And if you are suspecting primary or secondary membranous nephropathy, subclassification of this IgG, whether it's IgG 1, 2, 3 or 4, which is deposited, we can see. And if you are suspecting monoclonal deposits, kappa lambda stains are used. So electron microscopy is useful if that LM and IF is not conclusive. And it should be done in any patient with nephrotic proteinuria, because podocytopathy you may not pick up in LM or IF also. So only electron microscopy only will pick up the podocytopathies. What type of, whether it's a minimal change FSGS or if it is a membranous nephropathy or some like organized deposits like amyloidosis, fibrillary GN, immunotactile, EM should be done. And this can be useful to look for the location of the immune deposits, subepithelial or subendothelial or intramembranous. Electron microscopy is essential. So this is a picture of a normal glomerulus. Here you can see the capillary loops contains only just endothelium, endothelial nucleus only, and mesangium. So in between the capillaries, this pink color deposits and all, this normal mesangium actually. Here, this is a PA stain, which is useful to pick up the membranes. This is a Bowman's capsule, and it will show the bright violet color actually. This is the silver stain, also useful to pick up the matrix as well as the membranes. So it will show dark black color actually here in silver stain. This is electron microscope. This is a case of membranous pattern. It's not a membranous nephropathy, membranous pattern actually. So here the membrane is a PA stain, which is showing this thick Bowman's capsule. So it is showing the glomerular basement. Compared to that initial picture, you can see the capillary walls are very much thickened. And if you see this silver stain, you can see multiple spikes here. It indicates some subepithelial deposits. This is the immunoperoxidase stain of the plateau or antibodies. This is a MPGN pattern. MPGN pattern is classically has the lobular appearance. Like you can see different lobules. This and glomerular, it's MPGN is membranoproliferative. Membrano means membranes will be thickened, sometimes double contouring you can see. Proliferative means you can see lots of inflammation. So here membranes you can see, here you can see double appearance, here also you can see double appearance, and this is a single capillary, that is a capillary showing this inflammatory cells inside, not a single cell, not a one cell, so multiple cells are seen. This is a mesangial pattern. Usually mesangium will contain only one or two mesangial cells. If you see more than two cells in the mesangium, it is a mesangial hypercellularity. Here it is, you can see this is a mesangial part showing multiple nucleus, cell nucleus. So that indicates mesangial hypercellularity. This is a silver stain showing this expanded mesangial. Mesangial expansion means the size should be more than twice the size of a mesangial cell. This is an example of the crescentic GN. Crescents means you can see crescents. Usually crescents are seen in the Bowman space. So why these crescents are formed? Because of severe inflammation, it will cause, this is a one glomerular capillary loop which causes rupture of the capillary loop. This is a silver stain showing this discontinuation of the glomerular capillary wall. So because of this rupture, all the capillary lumen contents are extruded into the Bowman space. This will elicit inflammation in the Bowman space. That's why you can see lots of inflammatory cells in the Bowman space, like it will see like a crescent shape. So this indicates inflammation is very severe. So next is genetic testing. Genetic testing is not indicated for all the patients, but it is indicated in some special situations, like presenting in children, like if it is a nephrotic presentation in younger age group below 1 year of age group, or if the patient is having steroid resistant nephrotic syndrome, or patient is like infantile form or congenital form, or patient is having some syndromic features, then if you're suspecting some Alport syndrome like that, you have to do this thing. Our patient is having the family history, you have to do this genetic testing. On complement mediated diseases, whether the patient is having complement deficiency, you have to rule out complement genetic defect also. So coming to the management of glomerular diseases, this include general management for both conservative, non-immunosuppressive management, then management of complications, then disease specific. I'm not going into this topic, these two only I'm going to touch now. So general measures. So all patients with nephrotic or nephritic presentation, you have to manage the hypertension, control the proteinuria, manage the edema. So lifestyle modification is important. You have to advise the patient sodium restriction and protein restriction. Generally, it is not required because many of these patients are hypoalbuminemic. If you restrict further proteins, even though they look puffed up, they are undernourished. So you should not advise the patient to restrict the protein too much. Okay, as per the KDIGO recommendation for nephrotic syndrome, they can take the normal protein 1 gram per kg per day, 1 to 1.2 gram per kg per day, plus extra some 15 to 20 gram to replace the loss in the urine. then these patients are more prone to develop, they will have this dyslipidemia, hypertension, they are more prone to cardiovascular problems. So heart healthy diet, they have to maintain the body weight, physical activity is important, smoking and alcohol consumption should be stopped. And for to control the protein leakage as well as edema, you have to use the ROS blockade. And nowadays the SGLT2 inhibitors also in pipe, and the diuretics. You can use non-ROS blockage also. And regarding other considerations like anticoagulation to avoid the complications, if you are giving immunosuppression in younger patients, you can advise the patient to use the contraception. They are at risk of infections because of general low immunity as well as immunosuppressive medications. You have to immunize the patient, and prophylaxis is also important. So regarding the nephrotic edema, as I told you, can be in nephrotic syndrome, it is underfill theory. It's a nephritic, it is overfill theory. So both the patients, you have to advise salt restriction. Mainly salt restriction is like 4 to 5 grams per day. That means sodium restriction 1.5 to 2 grams per day, along with the diuretics. Generally, these nephrotic patients may not respond to diuretic. They are diuretic resistant because usually they are underfilled. Intravascular will be very low, so their ROS activation will be more. Third thing is because of hypoalbuminemia, diuretics will not work because albumin is important for the diuretic secretion, and even if it is secreted also, patient is having albumin excretion in the urine. That albumin bind to the secreted diuretics. It will not allow, that free form is essential for the action. It will not allow the drug to become free. So that will not, and that's why these patients are resistant to these diuretics. So generally these loop diuretics are preferred. Usually we start with oral, like a split dose, morning and oral dose is morning and evening, like that. If the patient is not responding, you can add second drug, another class of diuretic, because if you use only one diuretic, they may develop this diuretic resistance. And if still the patient is not responding to this combination diuretics, you can give IV. Okay, IVs instead of bolus, you can use the infusion, because bolus dose will cause side effect like ototoxicity is more common with the bolus dose. So always prefer this infusion. If still patient is not responding to diuretic infusion, next step is you have to go with albumin infusion with the diuretics. Usually we give albumin with the diuretics. In the albumin itself, you can add the diuretic. If still the patient is not responding, next step is ultrafiltration to stabilize the patient. Usually this water restriction is not necessary in nephrotic syndrome because they are already underfilled. If you restrict the water, they become hypolimic, then it will lead to AKN. Next is hypertension management. So hypertension is also more common in the nephritic syndrome than the nephrotic syndrome. So all patients, you have to target the BP below 120, 80 millimeter mercury. Okay. So the preferred drug is angiotensin converting enzyme or ARBs. Second, so if you are starting this AC or ARBs, you have to advise the patient to monitor the creatinine after 48 hours. If up to 10 to 20% increase is normal with ARBs. If the patient is having more than 30% increase in creatinine after starting this ARBs, then you have to stop it. The patient may have some other issue also, so you should not use that. Second, next line is you can use the mineralocorticoid receptor antagonist. Nowadays, this phenyrenone is coming in pipe. So next is dyslipidemia management. Generally, this nephrotic syndrome, like MCD and all, if you treat the underlying MCD, usually the dyslipidemia also will improve. So these type of patients, generally it is not required actually. But even after treating with immunosuppression, patient is not attained remission, patient is having persistent proteinuria, hypertension, having dyslipidemia, with or without dyslipidemia also, you can start with hypolipidemic agents. So what is the reason for this dyslipidemia in this patient is due to excessive cholesterol production, due to excessive activation of this HMG-CoA reductase, or reduced lipoprotein lipase levels, or increased LDL, VLDL production. All this leads to dyslipidemia. So all these patients, you have to advise same lifestyle modifications common for all the patients. Along with, you can use the statins. Thrombotic complications, because nephrotic syndrome per se is a procoagulant state because of loss of clotting factor like antithrombotic factors in the urine and excessive synthesis of the procoagulant factors. So this is just flowchart showing this what is the mechanism of this hypercoagulability, and these thrombotic complications are more common in adults than in children. Whereas if it is occurring in the children, it is more severe. They may present CVT, seizures. Whereas in adults, venous thrombosis is more common than arterial thrombosis. In that, DVT is more common than the pulmonary embolism. So among the glomerular diseases, this membranous nephropathy is most commonly associated with thrombotic complications. So how will you manage this patient? If the patient already developed some thrombotic events, arterial or venous thrombosis, you have to treat like a general population. You have to treat with IV heparin. Up to 6 to 12 months you can give. You can don't give IV heparin for a long time. So you can change it to warfarin also. Whereas prophylaxis for the patient is first time diagnosed with nephrotic syndrome, when to start prophylaxis? If the patient is having very severe hypoalbuminemia, like less than 2.5 grams, or patient is having other risk factors for thrombosis, you have to start with prophylaxis. If the patient is having other risk factors for bleeding and all, don't start this. So when the patient is coming to the hospital first time, if the patient is having severe hypoalbuminemia, albumin cutoff is less than 2.5 grams, with a high risk of thromboembolic risk, there are lots of tools are available online. If the risk is high, start with like bleeding risk is low, you can start with warfarin. If the bleeding risk is high, start only with aspirin, antiplatelets alone. If the patient is having serum albumin more than 2.5 grams but less than 3 grams, you have to estimate the risk of thromboembolic risk. If risk is high, start with aspirin only. If the risk is low, no need of anything. Then infection prophylaxis. All these patients are more prone to develop infections because of loss of immunoglobulins in the urine or loss of complement factors in the urine. So because of loss of these immunoglobulins and complement factors, they are more prone to develop capsulated organisms related infections. So in children it can, and also these patients are so much puffed up. They may have minor skin cracks and all because of stretch marks and all will be there. So even minor injury also will allow the organism to enter into the skin, produce local cellulitis, or sometimes they may present peritonitis. Meningitis also possible with these capsulated organisms. So many patients, as per KDIGO, it recommends to give vaccination, pneumococcal vaccine, influenza vaccine, and string inactivated vaccines, killed vaccines. You should not give live vaccines because most of the patients we are going to start immunosuppression that may precipitate vaccine-related complications. And before starting any immunosuppression, you have to screen the patient completely. Where the patient is having any evidence of TB or any other infection, you have to rule out the infection first, because if you start in immunosuppressive medication, that will cause relapse of the infection or worsening of the infection. Then deworming is necessary for all the patients. Then if you're starting steroids or any higher immunosuppression, septron prophylaxis is important. Then finally, the disease specific treatment. After giving all this supportive treatment, you have to first, based on the biopsy finding, based on the serological findings, based on the diagnosis, you have to treat the patient. Like minimal changes, steroids, MCD and all, steroid plus second line immunosuppression. Most of the immune complex SLE and all, like cyclophosphamide and all required. So with this disease specific treatment, you have to give chemoprophylaxis. That is very important. Okay, thank you. Any questions?
Thank you, Dr. Jayaprakash, for that lecture. Even though it was a vast topic, you had started with the basics of hematuria and proteinuria and then gone to the approach of how to approach nephritic or nephrotic syndrome in a way which all of us can understand. Thank you once again. If there are any questions. If there are no questions, thank you, Dr. Jayaprakash, once again for that lecture. The post-test link is available in the Department of Medicine WhatsApp page. And please join us for lunch. Lunch is provided at the web. Thank you.